Welcome. In this session and the next we'll be discussing about vitreous and vitreoretinal interface disorders. These include hereditary vitreoretinopathies, which we have discussed in an earlier session, developmental vitreous anomalies, vitreous degenerations and opacities, vitreoretinal interface disorders, and vitreous hemorrhage. We'll be discussing about vitreomacular traction syndrome and full thickness macular hole in the next session and vitreous hemorrhage in a subsequent session. Developmental vitreous anomalies include remnants of tunica vasculosa lentis and hyaloid artery. Tunica vasculosa lentis and hyaloid artery, which is a component of primary vitreous, provide nourishment to the fetal lens prior to aqueous humor production. The anterior portion of the tunica vasculosa lentis extends over the anterior surface of the lens and attaches to the pupillary margin, and the posterior portion of the tunica vasculosa lentis extends over the posterior surface of the lens, attaches to the ciliary processes, and is continuous with hyaloid artery. Tunica vasculosa lentis normally regresses shortly before birth but may be detected in 95% of premature infants and 3% of full-term infants, as seen here in this clinical photograph. Remnants of tunica vasculosa lentis and hyaloid artery include Mittendorf dots, persistent pupillary membranes, Bergmeister papilla, and persistent fetal vitreous. Mittendorf dots are remnants of posterior portion of the tunica vasculosa lentis and anterior portion of the hyaloid artery, as seen here in these two clinical photographs. A Mittendorf dot appears as a small dense and white round plaque on the posterior capsule of the lens located inferonasal to the posterior pole of the lens, and on retroillumination Mittendorf's dot appears dark, as seen here in this photograph. This clinical photograph shows a Mittendorf dot with an attached cloaca canal in which the hyaloid artery resides in fetal life. Mittendorf's dots are not visually significant. Persistent pupillary membranes are remnants of anterior portion of the tunica vasculosa lentis lying on the anterior surface of the lens, as seen here in these two clinical photographs. These membranes characteristically have their peripheral attachment at the iris collarate and not at the pupillary margin. Bergmeister papilla, as seen here in this clinical photograph, is a remnant of the posterior portion of hyaloid artery and appears as a fibroglial tuft of tissue extending from the margin of the optic disc anteriorly into the vitreous cavity. Unlike Mittendorf dots, Bergmeister papilla are not visually significant. And persistent fetal vitreous, which we have discussed earlier as a differential diagnosis of retinopathy of prematurity, occurs when the hyaloid artery, either the entire artery or its anterior or posterior portion, fails to involute. This clinical photograph shows a persistent patent posterior portion of a hyaloid artery. Prepapillary vascular loops are retinal vessels and not hyaloid artery, which extend anteriorly for a short distance into the vitreous cavity before returning to supply the respective quadrant of the retina. It is said to grow into a Bergmeister papilla, and most of the retinal vessels making up prepapillary vascular loops are arteries, and so prepapillary vascular loops may be associated with transient visual loss, branch retinal artery occlusion, and vitreous hemorrhage. Vitreous degenerations and opacities include diabetic vitreopathy, myopic vitreopathy, Asteroid hyalosis, cholesterolosis, pigments in the vitreous cavity, vitreous amyloidosis, and posterior vitreous detachment. Diabetic vitreopathy occurs due to increased levels of advanced glycation end products in the vitreous cavity, which leads to increased cross-linking between vitreous collagen fibers, resulting in earlier transition from clear vitreous of a young eye to a more fibrous vitreous. Vitreoschisis, which we will be discussing later in this session, is also more common due to early liquefaction of gel vitreous in diabetic eyes. As we have discussed in the session on proliferative diabetic retinopathy, posterior vitreous cortex can act as a scaffold for fibrovascular proliferation in eyes with proliferative diabetic retinopathy. A complete posterior vitreous detachment in an eye with proliferative diabetic retinopathy portends a better prognosis with a reduced risk of vitreous hemorrhage and tractional retinal detachment as compared to an eye with proliferative diabetic retinopathy, but with an attached posterior vitreous cortex, whereas an eye with proliferative diabetic retinopathy with an incomplete posterior vitreous detachment have the worst prognosis in this regard. Myopic vitreopathy refers to liquefaction of vitreous gel and anomalous PVD with vitreous cases, which we will be discussing later in this session in myopic eyes, in which these occur more commonly and earlier in life. Myopic vitreopathy increases the risk of myopic foveus cases in posterior pole, which we have discussed in the previous session, and retinal tears in the periphery. Asteroid hyalosis, as seen here in this clinical photograph, is the presence of small spherical yellow-white opacities scattered uniformly throughout the vitreous cavity. These opacities are composed of calcium-containing phospholipids. Prevalence of asteroid hyalosis has been estimated to be 1 in 200 individuals, and the prevalence increases among individuals over 50 years of age. Most of the presentations of asteroid hyalosis are unilateral, and what is most important is, despite its clinical appearance, asteroid hyalosis rarely affects visual function, which is very important to remember. Some studies have found association of asteroid hyalosis with diabetes and hypertension, and despite difficulty in ophthalmoscopic examination of retina in eyes with asteroid hyalosis, fluorescent angiography can be performed adequately through these opacities. USGB scan of an eye with asteroid hyalosis shows granular-shaped, highly echogenic opacities in central vitreous cavity, which remain visible even in low gain, with a clear band devoid of these opacities anterior to the posterior vitreous cortex. Vitrectomy to remove these opacities may be required if visual function decreases, which occurs very infrequently in these eyes, or retinal treatment such as laser photocoagulation becomes necessary. Cholesterolosis, also known as synchiasis scintillans, is the presence of yellowish white golden or multicolored highly refractile opacities in the vitreous cavity as well as in the anterior chamber. It almost exclusively occurs following significant vitreous hemorrhages, and the opacities are made up of cholesterol containing crystals. As it occurs typically following PVD, the opacities tend to settle inferiorly in the vitreous cavity. So unlike asteroid hyalosis, cholesterolosis occurs following vitreous hemorrhage, can be present in the anterior chamber, and is distributed non-uniformly in the vitreous cavity. These two clinical photographs show cholesterolosis opacities in the anterior chamber before and after surgery to wash out these opacities from the anterior chamber. Following surgery, cholesterolosis opacities reappear in the anterior chamber as they migrate from the vitreous cavity. Pigment cells may be detected in the anterior vitreous during slit lamp examination, as seen here in this clinical photograph, and they indicate the presence of a retinal break, and this is called the Schaffer sign. These pigment cells are actually dislodged retinal pigment epithelial cells. Vitreous amyloidosis can cause early bilateral vitreous opacification in dominantly inherited hereditary familial amyloidosis, which is most commonly due to transthyretin mutation. It may be associated with amyloid deposition in other ocular, extraocular, and non-ocular tissues. Vitreous involvement occurs very infrequently in non-familial amyloidosis. Retinal manifestations include cotton wool spots, hard exudates, hemorrhages, and peripheral neovascularization due to deposition of amyloid in the retinal vessels, and vitreous opacities appear initially adjacent to retinal vessels as granular opacities with wispy margins. Later, these opacities extend more anteriorly in the vitreous cavity, enlarge and aggregate, following which the vitreous cavities have a glasswool appearance. Differential diagnosis can include long-standing vitreous hemorrhage, lymphoma, and uveitis, and vitrectomy may be required to improve media clarity, but recurrences of these opacities are common. Vitreous biopsy shows the typical features of amyloidosis. We will be discussing about vitreous hemorrhage in a later session on intraocular hemorrhages. The vitreoretinal interface consists of the posterior vitreous cortex, the inner limiting membrane, which is the innermost layer of the neurosensor retina, and the intervening extracellular matrix between these two layers. Posterior vitreous detachment is the separation of the posterior vitreous cortex from the inner limiting membrane. Incidence of posterior vitreous detachment has been estimated to be 10% below 50 years of age and 63% above 70 years of age. So posterior vitreous detachment does not occur in every individual. Incidence of posterior vitreous detachment is higher in myopia, in which, as we have mentioned, it occurs at a much earlier age with inflammation, with vitreous hemorrhage, and following trauma and cataract surgery, particularly with a ruptured posterior capsule. With age, vitreous liquefaction or synchisis occurs along with collapse or syneresis of residual gel vitreous due to aggregation of collagen fibers in the gel vitreous. The liquefied vitreous contains mostly hyaluronic acid, whereas the gel vitreous contains collagen with a reduced amount of hyaluronic acid, which leads to aggregation of the collagen fibers. Liquefied vitreous exits posteriorly into the retrocortical or preretinal space, either through the prepapillary hole or through the premacular vitreous cortex, where there is a hole or a thin vitreous cortex, and this liquefied vitreous then dissects between the posterior vitreous cortex and the inner limiting membrane. The posterior vitreous cortex then separates from the retinal surface, usually in stages, followed by collapse of the vitreous body. In the posterior pole, this separation occurs first in the paramacular or mid-peripheral fundus, followed by the perifoveal retina, then from the fovea, and finally from the optic disc, which is the site where the posterior vitreous cortex remains attached the longest. This sequence is very important to understand the pathogenesis of vitreomacular traction and macular hole, which we will be discussing in the next session, and we will be discussing this sequence again when we discuss the OCT features of an eye with posterior vitreous detachment. Complete posterior vitreous detachment is diagnosed when posterior vitreous cortex gets detached from optic disc as well as the entire retinal surface except at the vitreous base. A sudden onset or increase of floaters heralds the onset of posterior vitreous detachment. We may note here that asteroid hyalosis does not cause floaters. Floaters can arise from aggregated collagen fibrils in gel vitreous, collagen fibers in detached posterior vitreous cortex, peripapillary tissue attached to detached posterior vitreous cortex, which is also known as vice ring, or concomitant vitreous hemorrhage, any of which can cast shadow on the retina. Since aggregated collagen fibrils in gel vitreous can cause floaters, floaters can be perceived even before PVD starts. Floaters appear to the patient as moving gray opacities, with the movement increasing with ocular rotations. Floaters can significantly reduce contrast sensitivity, which is also known as vision degrading myodysopsia, and floaters can also have a significant negative impact on quality of life. But over time, symptoms of floaters tend to diminish, either because the aggregated collagen molecules tend to settle inferiorly or because the brain learns to ignore the perception of floaters. The other symptom of posterior vitreous detachment is flashing or photopsia, which occurs due to vitreoretinal traction at sites of persistent vitreoretinal adhesion, but only 50% of patients with acute PVD perceive flashes. The flashing perception is usually vertical and located in the temporal quadrant, irrespective of the site of vitreoretinal traction. Peripapillary tissue, chiefly fibrous astroglia and collagen, torn away from optic disc margin during posterior vitreous detachment, can remain attached to the margin of the prepapillary hole in the detached posterior vitreous cortex, as seen here in this photograph, and this is called the vice ring. Sometimes the detached posterior vitreous cortex can be identified as a near translucent light gray sheet or opacities anterior to the retina. Following posterior vitreous detachment, on ultrasound B scan, the detached posterior vitreous cortex appears as a thin hyperechoic line at high gain, which disappears at low gain, and this is in contrast to the imaging characteristic of retina, which remains visible in low gain. The detached posterior vitreous cortex is freely mobile with ocular movements and can be demonstrated to be continuous by moving the ultrasound probe across the anterior surface of the eye. If posterior vitreous detachment is complete, the detached posterior vitreous cortex will not appear to be attached to the optic nerve head. This is in contrast to a total retinal detachment, which remains attached to the optic nerve head. This image shows a localized vitreoretinal traction being caused by a detached posterior vitreous cortex. This image shows a horseshoe tear being attached to the detached posterior vitreous cortex, and this image shows the vice ring attached to the posterior vitreous cortex and hanging in the vitreous cavity anterior to the optic nerve head. With or without a posterior vitreous detachment, mild echogenic minute opacities can be detected at high gain informed or gel vitreous, which are absent in synertic or liquid vitreous. Posterior vitreous detachment can be graded on optical coherence tomography, and this grading, as we have mentioned, is very important to understand the pathogenesis of vitreomacular traction syndrome and macular hole. Grade 0 PVD refers to a posterior vitreous cortex that is completely attached to the macula. Grade 1 PVD refers to a posterior vitreous cortex that is detached from either the nasal or the temporal sector of the macula, as seen here in this OCT image. Grade 2 PVD refers to a posterior vitreous cortex that is detached from both the nasal and the temporal sectors of the macula while remaining attached to the central fovea, as seen here in this OCT image, which is also known as perifoveal detachment of the posterior hyaloid. Grade 3 PVD refers to a posterior vitreous cortex that is completely separated from the macula while still remaining attached to the optic nerve head, and grade 4 PVD or complete PVD refers to a posterior vitreous cortex which is completely separated from both the macula and the optic nerve head. Vitreoretinal interface disorders include epiretinal membrane pseudo-hole, lamellar macular hole, vitreomacular traction syndrome, and full thickness macular hole. We will be discussing about vitreomacular traction syndrome and full thickness macular hole in the next session. Most posterior vitreous detachment are innocuous, with complete separation of posterior vitreous cortex from inner limiting membrane without occurrence of any vitreoretinal interface abnormality. This is because during innocuous posterior vitreous detachment, vitreoretinal adherence decreases simultaneously with liquefaction of the vitreous gel, and this is a normal aging process. On the other hand, anomalous posterior vitreous detachment or APVD occurs when liquefaction of vitreous gel takes place without concurrent weakening of vitreoretinal adherence, resulting in vitreoretinal traction leading to vitreoretinal interface abnormalities. As we will discuss, the occurrence of these abnormalities are based upon the location of maximum gel liquefaction, the location of firmest vitreoretinal adherence, and the occurrence of vitreous cases. Risk factors for APVD include myopia, as we have discussed, and hereditary disorders such as Stickler, Marfan, and Ehlers-Danlos syndromes. Anomalous posterior vitreous detachment can occur with or without vitreous cases, which is splitting between the layers of the posterior vitreous cortex. Anomalous posterior vitreous detachment without vitreous cases leads to separation of the entire thickness of the posterior vitreous cortex from the retina, but the posterior vitreous cortex is not separated from the entire surface area of the retina, leading to a partial posterior vitreous detachment, resulting in perpendicular or axial traction on the retina at the site of residual retinal attachment of the partial posterior vitreous detachment. Such an APVD with posterior separation of posterior vitreous cortex from the retina with peripheral vitreoretinal attachment can lead to retinal breaks and retinal detachment. On the other hand, peripheral separation of posterior vitreous cortex from the retina with persistent posterior vitreoretinal attachment can occur at the fovea, leading to vitreomacular traction syndrome and macular hole, or at the optic disc, which can lead to vitreous hemorrhage from optic disc neovascularization or macular hole, along with vitreous cases at fovea, which we will be discussing next. Anomalous posterior vitreous detachment with vitreous cases results in the formation of preretinal membranes originating from the outer lamella of posterior vitreous cortex, which remains attached to the retina. The outer lamella of posterior vitreous cortex acts as a scaffold for fibrocellular proliferation, resulting in the formation of preretinal membranes which induce tangential traction on the underlying retina. Such a preretinal membrane located peripherally has been shown to play a role in the causation of proliferative vitreoretinopathy, which we have discussed in an earlier session. Similar preretinal membranes located posteriorly can be either thick and cellular, when the vitreous cases splitting occurs anterior to halocyte monolayer, or thin and hypocellular when vitreous cases splitting occurs posterior to halocytes. We may recall here that halocytes reside in the posterior vitreous cortex in a monolayer. In this situation, when vitreopapillary adhesion is present, the traction is directed centrifugally, that is outward from the foveal center, which can lead to the formation of macular holes. And when vitreopapillary adhesion is absent in an eye with a posterior preretinal membrane, the traction is directed centripetally, that is inward towards the foveal center, leading to the formation of macular pucker. The outer lamella of posterior vitreous cortex following vitreous cases can be stained with triamcinolone during vitreous surgery. Vitreomacular adhesion also plays a role in the pathogenesis of cystoid macular edema, diabetic macular edema, and neovascular age-related macular degeneration. An epiretinal membrane is an avascular fibrocellular proliferation on the inner retinal surface adhering to and covering the internal limiting membrane. It is also known as macular pucker and cellophane maculopathy. Clinical severity can range from being asymptomatic to debilitating metamorphopsia and central visual acuity loss. Prevalence of ERM ranges from 7% to 12%, and ERMs can be bilateral in up to 30% of affected individuals, but are usually asymmetric between the two eyes. And in patients with unilateral ERM, the 5-year incidence of ERM occurring in the fellow eye is around 14%, and ERM peaks in the 8th decade of life and is uncommon before 60 years of age. The most common type of ERM is idiopathic, but ERMs can also be secondary to a large number of ocular diseases or iatrogenic following ocular surgery. Secondary ERMs can occur following retinal vasculopathies, trauma, inflammation, proliferative vitreoretinopathy, after long-standing vitreous hemorrhage, in chronic intraretinal edema, and in retinal dystrophies. Iatrogenic ERM can occur following cataract surgery, laser photocoagulation or cryopexy, and retinal detachment surgery. ERM formation is considered as a form of reactive gliosis in response to retinal injury or disease. The vitreomacular traction exerted by posterior vitreous cortex during posterior vitreous detachment creates focal breaks in the internal limiting membrane, which induces proliferation and migration of Muller cells on the inner retinal surface. Also, schisis of the posterior vitreous cortex in an anomalous PVD, which we have discussed earlier in this session, leaves the outer lamella of the posterior vitreous cortex adherent to the retina, over which halocytes may proliferate and undergo fibrous metaplasia. The vector of tangential traction is centripetal, that is towards the foveal center, due to absence of vitreopapillary adhesion, as shown here in this diagram, resulting in folding of the underlying retina. An epiretinal membrane can also occur in the absence of posterior vitreous detachment when an undetached posterior vitreous cortex exerts vitreomacular traction, leading to Muller cell proliferation along the undetached posterior vitreous cortex. In these cases, occurrence of subsequent posterior vitreous detachment spontaneously detaches the ERM from the retina. Advanced ERM have higher content of contractile components, which lead to distortion of the underlying retina and retinal blood vessel, breakdown of blood-retina barrier, and fluid accumulation within the retina. Among secondary epiretinal membranes, proliferative vitreoretinopathy, which we have discussed in an earlier session, occurs due to fibrous metaplasia of retinal pigment epithelial cells, in which retinal glial cells also contribute, and epiretinal membranes secondary to inflammation, vascular diseases, and trauma occur due to leakage of inflammatory cells through compromised blood-retina barrier. An epiretinal membrane consists of an extracellular matrix containing collagen, laminin, fibronectin, and other extracellular matrix molecules, and cells, chiefly retinal glial cells, but also other kinds of cells such as halocytes and immune cells, and most of these cells are capable of myofibroblastic transformation, inducing contraction of the epiretinal membrane. We have discussed about myofibroblastic transformation in the session on proliferative vitreoretinopathy. An epiretinal membrane, as the name suggests, is closely opposed with the retina. A grade 0 epiretinal membrane, also known as cellophane maculopathy, appears as a translucent glistening membrane without any distortion of the underlying retina, as seen here in this clinical photograph, and so is asymptomatic and an incidental finding. The membrane is better seen with red-free light from a slit lamp or fundus camera. Grade 1 epiretinal membrane is also translucent and glistening in appearance, but cause wrinkling of the inner retina. Patients with grade 1 epiretinal membrane in the fovea may complain of metamorphopsia and blurred central vision, but may also have other symptoms such as macropsia due to crowding of photoreceptors, central photopsia due to vitreomacular traction, loss of binocularity, and rarely central binocular diplopia. Grade 2 epiretinal membranes appear opaque and grayish with obscuration of retinal vessels and marked full thickness retinal distortion, as seen here in this clinical photograph. Patients with grade 2 epiretinal membranes complain of more severe metamorphopsia and blurring of central vision, and these patients may also have dot blot hemorrhages, cottonwool spots, microaneurysms, hard exudates, and cystoid macular edema. A detached posterior vitreous cortex, typically an anomalous posterior vitreous detachment with vitreous cases, is found in the majority of patients with an epiretinal membrane, and this is very important to remember. In the remaining patients with an ERM and an attached posterior vitreous cortex, cystoid macular edema, as seen here in this OCT image, and lower visual acuity is more common. And when a posterior vitreous detachment occurs subsequently in these eyes, the epiretinal membrane may be spontaneously avulsed, as shown here in this color photograph. Other associated clinical features of an eye with an epiretinal membrane include inner lamellar macular hole, pseudohole, and full thickness macular hole. An inner lamellar macular hole is a discontinuity in the inner retinal layers in the foveal region, as seen here in this clinical photograph, which occurs from rupture of a preceding intraretinal cyst in the fovea. This intraretinal cyst may occur either due to traction from an epiretinal membrane or from a cystoid macular edema in the absence of an epiretinal membrane. So inner lamellar macular holes can occur in the presence of an epiretinal membrane, which we are discussing in this session, or in the absence of an epiretinal membrane from a cystoid macular edema, which we have discussed in a previous session. Inner lamellar macular holes associated with epiretinal membranes has been further classified into two types. Degenerative inner lamellar holes occur with hypocellular preretinal membranes, which usually do not contain myofibroblasts and are thus non-contractile, and tractional inner lamellar macular holes occur with hypercellular preretinal membranes, which usually contain myofibroblasts and are thus contractile. On ophthalmoscopy, an inner lamellar macular hole usually appears as a bi or trilobulated defect in the retina with a red center and a thin edge. A full thickness macular hole, which we'll discuss in the next session, also appears red in color but is typically round and has a thick elevated edge. Histopathology of inner lamellar macular hole, as represented by this OCT, consists of thinning of the fovea, partial loss of the inner nuclear layer, intact photoreceptor layer, and retinal pigment epithelial layer, clefting between the inner and the outer retina at the margins of the inner lamellar hole, and cystic changes in the retina with or without an epiretinal membrane surrounding the inner lamellar macular hole. To complete our discussion of lamellar macular holes, outer lamellar macular hole is the other type of lamellar macular hole in which there is disruption in the outer retinal layers, and typically outer lamellar macular holes are not associated with epiretinal membranes or other vitreoretinal interface abnormalities. Causes of outer lamellar macular hole include myopic maculopathy and optic disc maculopathy, which, as we have discussed in the previous session, are causes of foveous cases, as early stage of full thickness macular hole in solar retinopathy, as seen here bilaterally in these two OCT images, or may be idiopathic. A pseudohole appears as a gap in an epiretinal membrane which is reddish and round, oval, or irregular, associated with stiffening of the normal foveal contour into a U or V-shaped depression without loss of retinal tissue. It is caused by centripetal contraction of an epiretinal membrane, and patients with pseudoholes usually have normal to near normal visual acuity. Unlike idiopathic full-thickness macular hole, a pseudohole has wrinkling in the perifoveal retina, has retinal tissue at the base of the hole and does not have features of idiopathic full-thickness macular hole such as yellowish deposits in the base of the hole, edema of neurosensory detachment surrounding the hole, overlying operculum, and word-scaling test, which we will be discussing in the next session. Rarely, an epiretinal membrane can lead to a full-thickness macular hole due to tangential traction from an eccentric epiretinal membrane, and this is unlike idiopathic full-thickness macular holes which occur due to anteroposterior traction, as we will be discussing in the next session. On optical coherence tomography, an epiretinal membrane appears as a hyperdeflective membrane on the inner retinal surface, as seen here in these two OCT images. Associated findings include irregular contour of inner retinal surface, blunting of foveal contour, increased retinal thickness, and intraretinal cysts. Idiopathic epiretinal membranes appear uniformly adherent to the underlying retina, as seen here in this OCT image, while secondary epiretinal membranes, as seen here in this OCT image, demonstrate focal adhesions to the underlying retina, and this is important to remember. OCT-based grading of epiretinal membrane correlates with visual acuity and post-operative visual gain. Grade 1 epiretinal membrane has a normal foveal depression. Grade 2 epiretinal membrane has loss of normal foveal depression. Grade 3 epiretinal membrane has ectopic inner foveal layers, which is defined as presence of the inner nuclear layer and the inner plexiform layer in the central fovea, where they are normally absent. And grade 4 epiretinal membrane refers to ectopic inner foveal layers along with disorganization of the retinal layers. An OCT-based staging of abnormalities of the central bouquet, which is the central 100 micron zone around the foveal center, has also been described for eyes with epiretinal membrane, and it is hypothesized that traction from the epiretinal membrane is transmitted through the retina to the photoreceptors by Muller cells. Stage 1 or cotton ball sign refers to hyperreflective material between the ellipsoid zone and the interdigitation zone without disruption of the ellipsoid zone. And eyes with cotton ball sign usually show long-term stability of visual acuity and morphological appearance and may undergo spontaneous resolution. Stage 2 or foveal detachment is the presence of a hyporeflective pocket of fluid between the interdigitation zone and the retinal pigment epithelium. And stage 3 or acquired vitiliform lesion is a dome-shaped hyperreflective lesion between the ellipsoid zone and the retinal pigment epithelium. These central bouquet abnormalities have been shown to undergo structural resolution following epiretinal membrane removal. On optical coherence tomography, an inner lamellar macular hole has an irregular foveal contour with defect or tissue loss in inner retinal layers. The thickness of the foveal floor is irregular with undermined edges which do not appear thickened. Intraretinal splitting, typically between outer plexiform layer and the outer nuclear layer, may be present, but the photoreceptor layer is characteristically intact in eyes with lamellar holes. An epiretinal membrane can be found in 30% of eyes with inner lamellar macular holes on optical coherence tomography. As we have already mentioned, inner lamellar macular holes with ARM can be distinguished into two types. A degenerative inner lamellar macular hole, as seen here in this OCT image, in which the associated epiretinal membrane is medium reflective and which usually does not have either foveoschisis or distortion of the perifoveal retina, and a tractional inner lamellar macular hole in which the associated epiretinal membrane is hyperreflective and which usually has foveoschisis and distortion of the perifoveal retina. Eyes with epiretinal membrane with inner lamellar macular hole have a poorer prognosis as compared to eyes with epiretinal membrane only following epiretinal membrane peeling. A pseudohole appears as a defect in the epiretinal membrane without loss of any retinal tissue at the umbo. The edges of the foveal pit in a pseudohole appear hipped up with steep contours of the foveal depression and near normal foveal thickness. Intraoperative OCT can aid surgical removal of epiretinal membrane, and postoperative OCT can show improvement in foveal contour and macular thickness, although neither returns to normal, but that does not preclude gradual improvement in visual acuity. Opta show decreased foveal avascular zone area and decreased parafoveal vessel density in both the superficial and deep vessel plexuses in eyes with epiretinal membrane. Fluorescent angiography may demonstrate distortion of perifoveal retinal blood vessels in the zone of an epiretinal membrane and leakage in the macular area and staining of the optic disc in late frames of the angiogram. Macular edema from epiretinal membrane is not as symmetrical as cystoid macular edema from other causes, and fluorescent angiogram may detect underlying vascular cause of an epiretinal membrane if present. Majority, that is 75 to 90% of epiretinal membranes remain stable or are very slowly progressive over time in terms of both visual acuity loss and area of retina involved, and this is important to remember. Differential diagnosis of epiretinal membrane includes secondary causes of epiretinal membrane in which visual acuity is usually lower than expected for the appearance of the epiretinal membrane because of the underlying ocular disease, vitreomacular traction syndrome and full thickness macular hole, which we'll discuss in the next session, and cystoid macular edema from causes other than epiretinal membrane which shows no distortion of retinal microvasculature, is centered on fovea and shows petaloid leakage in late frames of fluorescent angiogram. Indication for ERM removal is primarily diminution of central visual acuity to less than 20/60, and this is important to remember. Significant metamorphopsia and diplopia should also be taken into account when deciding for surgery. Otherwise, ERM needs to be followed up periodically to detect worsening over time. Surgical procedure for removing epiretinal membrane involves vitrectomy with PVD induction followed by peeling of epiretinal membrane and internal limiting membrane. It has been shown that internal limiting membrane peeling reduces recurrence of epiretinal membrane but does not affect post-operative visual gain, and various vital dyes are used to improve visualization of these membranes, such as triamcinolone acetonide for posterior vitreous cortex, trypan blue for epiretinal membrane, and brilliant blue G for internal limiting membrane. Following surgical removal of epiretinal membrane, visual improvement starts to occur after several weeks. Up to 85% of patients have an improvement of 2 or more lines of visual acuity 6 to 12 months after surgery, but visual acuity infrequently reaches normal levels. And preoperative visual acuity is the most reliable prognostic indicator of post-operative visual gain. And recurrence of symptomatic epiretinal membrane can occur in 5% of patients undergoing surgical removal of epiretinal membrane. To recap the salient points, developmental anomalies of vitreous are remnants of tunica vasculosa lentis and posterior hyaloid artery. They include Mittendorf dot, which appears as a small white dot located on the posterior lens capsule inferonasal to the posterior pole of the lens. Bergmeister papilla, which appears as a fibroglial tissue projecting anteriorly from the margin of the optic disc into the vitreous cavity. Persistent fetal vitreous, which occurs due to failure of involution of the hyaloid artery, and prepapillary vascular loop, which is a loop of a retinal vessel into a Bergmeister papilla. Asteroid hyalosis, which presents mostly unilaterally, is the presence of small yellowish white dots uniformly throughout the vitreous cavity. The opacities are made of calcium-containing phospholipids and rarely affect vision. On ultrasound B scan, they appear as highly echogenic granular opacities in the central vitreous cavity with an opacity-free zone anterior to the posterior vitreous cortex. Cholesterolosis almost always occur following significant vitreous hemorrhage. These opacities, which contain cholesterol crystals, appear golden to brown in color, are distributed non-uniformly in the vitreous cavity, mostly inferiorly, and are often present in the anterior chamber also. Vitreous amyloidosis occurs in hereditary familial amyloidosis. Initially, the opacities appear granular with wispy margins, and later, the vitreous cavities have a glasswool appearance bilaterally. Associated retinal vasculopathy and amyloid infiltration of other ocular, extraocular, and non-ocular structures can be present. Posterior vitreous detachment occurs when liquefied vitreous passes through defects in the posterior vitreous cortex into the preretinal space and separates the posterior vitreous cortex from the internal limiting membrane. In the posterior pole, posterior vitreous detachment usually occurs in the following order: paramacular retina, perifoveal retina, fovea, and then optic disc. Posterior vitreous detachment is said to be complete when the posterior vitreous cortex detaches from the optic disc and the entire retina except at the vitreous base. Posterior vitreous detachment can be either innocuous or anomalous. Innocuous posterior vitreous detachment occurs when liquefaction of vitreous gel takes place simultaneously with decrease in strength of vitreoretinal adhesion, thus resulting in no vitreoretinal interface abnormalities. Anomalous posterior vitreous detachment occurs when liquefaction of vitreous gel takes place without simultaneous decrease in the strength of vitreoretinal adhesion, resulting in vitreoretinal interface abnormalities. Anomalous posterior vitreous detachment can be associated with vitreous cases which induces tangential traction on the retina, or anomalous posterior vitreous detachment can occur without vitreous cases which induces axial traction on the retina. Anomalous posterior vitreous detachment is known to occur in myopia and hereditary vitreoretinopathies in which liquefaction of vitreous gel occurs earlier in life. Symptoms of acute posterior vitreous detachment are flashes and sudden onset or increase in floaters. Floaters can reduce contrast sensitivity but typically diminish in severity over time. Following complete posterior vitreous detachment, a ring of peripapillary tissue may be seen to be attached to the detached posterior vitreous cortex called the Weiss ring. Ultrasound B scan shows a thin hyperechoic line at high gain which is freely mobile and which disappears at low gain. Following completion of posterior vitreous detachment, the membrane is no longer attached to the optic nerve head on ultrasound B scan. OCT scans can show the stages of PVD in the posterior pole. Epiretinal membrane, also known as cellophane maculopathy or macular pucker, is a fibrocellular proliferation developing over the inner surface of internal limiting membrane, which is said to occur when posterior vitreous detachment induces focal breaks in the internal limiting membrane, resulting in proliferation and migration of chiefly retinal glial cells over the internal limiting membrane. An epiretinal membrane can exert tangential traction on the retina. Majority of epiretinal membranes are idiopathic. Secondary epiretinal membranes occur following other ocular diseases such as retinal vasculopathies, trauma, inflammation, vitreous hemorrhage, proliferative vitreoretinopathy, and retinal dystrophies. Iatrogenic epiretinal membranes can occur following cataract surgery, laser photocoagulation, cryopexy, and vitreoretinal surgery. Symptoms of epiretinal membrane may vary from nil to disabling metamorphopsia and/or loss of central visual acuity. Early stage epiretinal membrane appears as a translucent membrane on the retina in the posterior pole with or without distortion of underlying retinal vessels. Later, the epiretinal membrane may become opaque. Epiretinal membranes can lead to inner lamellar hole, pseudohole, and very infrequently full-thickness macular hole formation. On optical coherence tomography, an epiretinal membrane appears as a highly reflective membrane on the surface of the retina with or without distortion of foveal contour, ectopic inner foveal layers, disruption of inner retinal layers, cystoid spaces, and abnormalities of the central bouquet. Idiopathic epiretinal membranes are typically uniformly adherent to the retina, while secondary epiretinal membranes are typically adherent to the retina only at several foci. Optical coherence tomography can also distinguish between pseudohole lamellar macular hole and full-thickness macular hole. Differential diagnosis of epiretinal membranes include vitreomacular traction syndrome, full-thickness macular holes, and cystoid macular edema from causes other than epiretinal membrane. Majority, that is more than 75% of epiretinal membranes, are either non-progressive or very slowly progressive over time, with visual acuity rarely becoming worse than 20/200. Surgery to remove epiretinal membrane is indicated when visual acuity becomes worse than 20/60 and or there is disabling metamorphopsia. Visual acuity improves in the majority of patients after surgery but takes 6 months to 12 months to occur and rarely reaches normal levels. Thank you for listening.